Um, okay, so today Dr. Diana Munoz-Mendoza, who is one of our senior allergy immunology fellows, is going to present grand rounds and picked a timely topic, summertime, stinging insect hypersensitivity. So, Diana.
Well, we're gonna start the talk. Okay. So I have anything to disclose. The objectives of this lecture is to discuss the clinical manifestation of an allergic reaction by a stinging insect. We're gonna discuss the treatments and we're gonna talk also about when to refer a patient to the allergy clinic to be evaluated because of insect allergy. At least 40 fatal stings occur each year in the United States, and the insect allergy causes more than 10% of all cases of anaphylaxis that are treated on the emergency department. The systemic reactions are more common in adults. 3% and almost 1% of the children have a history of severe sting reactions. Systemic reactions, as we say, more common in adults, young adults, but deaths are more likely in adults more than 45 years of age. And this may be due to impaired compensation to these sudden physiologic changes. These are all the insects that are known to cause allergic reactions in humans. The ones that cause systemic reactions are from the hymenoptera order, and these are stinging insects. And stings in general increase the systemic exposure to the insect antigens, and also because of the chemical nature of the insect venom. The Diptera order that includes the mosquitoes, these are biting insects, and we can develop allergic reactions to the salivary proteins, but these are mainly local reactions. In very rarely cases, they can cause a systemic reactions. So most of these insects called local reactions, just hymenoptera is the one that we're gonna talk today. So the hymenoptera order, they have a sting apparatus, is a modified ovipositor, and therefore only females insects can sting. Most insects sting primarily in defense of themselves or their nest, and there is three families that are more important in insect allergy: Apidae, Vespidae, and Formicidae. So these are the different groups. So the first family, the most common is honeybee and bumblebee. These are the common names. And Vespidae, it has two subfamilies and include yellow jacket, yellow hornet, white-faced hornet, and paper wasp. And in the last family, the Formidae, includes the fire ant. So we're going to talk about a little bit of the characteristics of each of these insects because it helps to differentiate the nature of the sting or which was the insect that caused the reaction. So honeybee, the nest is, they nest in a natural hollow, such as in trees, and they rarely sting or swarm without any considerable provocation. They have something that is called a sting autonomy, so that means that they have, the sting apparatus is barbed, and it breaks away from the body when it remains in the skin after a sting. And because of this, eviscerates the insect, and later on after stings, the insect die. The The Africanized honeybee, that doesn't appear any different from the domestic honeybee. However, Africanized bees have tendency to swarm with little provocation and to sting in large numbers. Usually they cause toxic reactions that can be fatal because of the large number of stings, and that's why these bees are called killer bees. This is bumblebee. They are not aggressive, and they are known because of the fuzzy appearance hair and also the loud buzzing sound. The Vespids, they have the characteristic of the nest. They have the comb layers are attached in a vertical arrangement, and they are enclosed in a papier-mâché outer layers. The sting apparatus, the barbs that they have are fine. That's why they don't leave the stinger in the skin, so they are able to sting repeatedly. However, although this sting autonomy is more characteristic of honeybee, there are some species from the Vespid order, from the Vespid subfamily, that can also have a sting autonomy. And we can see here the difference between the stinger. This is a wasp, and this is a bee. We can see it better here. So the barbs are bigger on the honeybee, and this allows the stinger to stay on the skin. The yellow jacket, these are scavengers. They seek their food at picnics, orchards, trash can, and dumpsters. They are highly aggressive, and they sting for no apparent reason. In particular, in the autumn, when there are large populations that are competing for food. The nests are located on the ground, but also on cracks in buildings. Yellow hornet and white-faced hornet, they have their nest in shrubs and trees, and they have a special sensitivity to vibration that can initiate their defensive behavior. Okay, and the paper wasp, these are characterized by the narrow waist and the dangling legs when they fly. They are less aggressive than the yellow jackets and the hornets, and they can also sting repeatedly without losing their sting apparatus. And here we have a fire ant. They are widespread in the southeastern. They have a true sting apparatus, so when they bite, they anchor by their mandibles, and pivot to administrate multiple stings. And the characteristics of the lesions that cause fire ant, we will see them in another slide. They cause like a small pustules. And this is the distribution for fire ant. They are cold intolerant, and we see them spread around the south of the United States, all the way from California to Maryland. So the venom from the flying insects, from Apidae and Vespid, they have a non-allergic component and an allergic component. The non-allergic component is gonna be mainly vasoactive amines, histamine, dopamine, norepinephrine, as well as acetylcholine and kinanes that can cause the burning sensation, the pain, and also some itching. However, if they sting several times, they can cause also toxic reactions that can lead to renal failure due to rhabdomyolysis. And the allergic component is mainly enzymes. The phospholipase A is the major allergen in honeybee venom, and the antigen 5 is the major allergy on the Vespid venoms. The fire ant venom, they contain very little protein in a suspension of alkaloid toxins that is called transpiperidine, and this is the one that causes some necrosis of the tissues and the characteristical vesicular eruption. The clinical spectrum of the venom allergy can be divided as according to the pathophysiology, so that means if they are reactions that are allergic or non-allergic, and allergic, it can be IgE or non-IgE mediated. And according to the extent of the reaction, the reactions can be local or systemic. And when we talk about local reaction, that means that they are limited to the area contiguous to the insect site. Most stings are going to cause some local reaction, pain, swelling, and redness, and these usually tend to resolve within a few hours. This is like the normal reaction. Fire ant, it causes these sterile pustules that develop within 24 hours of the stings. This is due to the alkaloids on the fire ant venom. These lesions are not painful, and even though they have a purulent appearance, this is not an infection and should not be treated with antibiotics. Large local reactions. So we talk about large local when they are abnormally large and they are contiguous to the insect site. The diameter usually is more than 20 centimeters, and they can extend across the joint lines, and actually they may be involved the entire limb. They develop after 12 to 24 hours, and they last for 5 to 10 days. And these reactions represent a late phase IgE-dependent reaction. These reactions are not life-threatening, except if they develop, for example, on the tongue, on the throat, the face or the neck, where there is the potential of anatomic compression. They can also develop lymphangitic streaks, and this is due to the lymphatic drainage of mediators, but is not necessarily an infection. The systemic reactions can be IgE-mediated reactions, can be also toxic reactions, or can be reactions due to anxiety after the insect sting. The IgE-mediated reactions, these are manifestations that are not contiguous to the site of the sting, and they range from mild to life-threatening reactions. Patients can have cutaneous systemic manifestations like urticaria and angioedema, or they can have anaphylaxis, which includes hypotension or at least 2 organ systems involved. And these are the symptoms that they can develop. So they can have the cutaneous manifestations, they can have respiratory distress because of bronchospasm. They can have upper airway obstruction due to the swelling of the throat, the tongue, or the laryngeal edema. They can also have cardiac manifestations with arrhythmia, or something that we know as a Conus syndrome, that is coronary artery spasm due to an allergic reaction that resembles like a myocardial infarction. The patients can have also hypotension and shock. They can have nausea, vomiting, diarrhea, or even seizures. The IgE-mediated reactions, when there is absence of urticaria and angioedema, this is more associated with the more severe reactions. And in general, the vascular symptoms are less often in children. In children, it's more common to see cutaneous manifestations. There are other reactions that have been related with hymenoptera sting, and these are delayed reactions of so far unknown mechanism, like serum sickness-like reactions, encephalitis, peripheral and cranial neuropathies, glomerulonephritis, myocarditis, and Guillain-Barré syndrome. Toxic reactions, these occurred when a large number of insects produce like several stings on the patient, and this can cause a massive envenomation that can lead to rhabdomyolysis, hemolysis, acute respiratory distress, renal failure, and even diffuse intravascular coagulation. The seizures have also occurred, particularly on fire ant stings. Anxiety reactions, these are the patients complain of subjective symptoms without any objective signs of reaction. However, the pattern, the timing, and also the response to the treatment can help us to differentiate and clarify the nature of the reaction. So we're going to talk about now about the management. So this is just as like a general knowledge if you happen to be in, during the insect sting. So we should not take the stinger with these dressers, because this can lead to the we can squeeze the venom more through the skin. So in theory, we should scrape it off with a nail or with a gauze. The treatment of the acute reactions is cold compresses, is analgesics because the patient is going to be on pain, antihistamines, and in some cases, the patients may need oral corticosteroids in 40 to 60 milligrams for 5 days. This is in adults. And in kids, 1 to 2 milligrams per kilogram per day. In patients that we know that they have large local reactions, we can even start oral corticosteroids immediately after the sting. And antibiotics are not necessarily, because this is more likely not an infection. So the treatment of the systemic reactions of the treatment of anaphylaxis is with epinephrine, and the dose, the same as in other anaphylactic reactions for other reasons, 0.3 to 0.5 in adults, and for kids, 0.01 milligrams per kilogram in children of the 1 to 1,000 solution. The administration of the epinephrine needs to be on the anterolateral aspect of the tide, and it doesn't matter if you are on the emergency department or if the patient has the EpiPen with them, needs to be exactly on the same place and intramuscular. The patients with history of a rapid onset and very severe systemic reactions, they need to have the epinephrine immediately after, and we're going to talk about education for the patients. And this is the reason why we need to give the epinephrine intramuscular with the correct needle, because it has been demonstrated that the time of the maximum plasma concentration after the injection is reached faster with the intramuscular administration than with the subcutaneous way. So we need to educate the patients. If we see a patient who had an anaphylaxis due to insect sting, before discharge, they need to know how to use epinephrine autoinjector, and they need to be referred to the allergy clinic for evaluation. And this is because there is the possibility of giving treatment with Venom immunotherapy or Venom allergy shots. Sometimes the patients may think the reaction was just a chance occurrence, and they even fail to inform the PCP later on. So that's why if you see a patient on the emergency department, it will be a good idea even to start referring the patient to the allergy department. And these are the brands that we have available for epinephrine autoinjector. We have the Avicue, the EpiPen, and also some generic epinephrine autoinjector. The Avicue is the one that has 3 different concentrations. So it's the 0.3, the 0.15 that is given in general for children below the 30 kilograms, okay? And there is one that is the neonatal Avicue that is given below the 10 kilograms. This is the EpiPen, and it has 2 presentations. One is the junior, the 0.15, okay, and the adult is the 0.3 milligrams. The difference also, the Avicue is the one that we can play a message, like a record instructions on how the patient needs to administrate Avicue, and just as a reminder, the epinephrine needs to be given over the skin. So this picture is over the clots, but in general, you need to educate the patient to administrate correctly the epinephrine. All the patients needs also to be advised to have a medical ID in order, in case something happened, that if adults or children, if they are with someone that doesn't know that we're allergic to, they need to have this information with them. And when are we going to refer a patient to the allergy clinic? So patients with history of a systemic reactions of a stinging insect, or even if you are not sure if this was a systemic reaction, it's better to send them to the allergy clinic. We can evaluate them and we can decide if the patient needs a further workup. When are we going to send them? So in general, immediately after you know that they have a history of a systemic reaction, but we usually do a skin testing 4 to 6 weeks after the sting reaction. And why? So the reason for sending patients to the allergy clinic is because after a lot of studies regarding the risk of other reaction, we know that people who has history of a systemic reaction has a 50% risk of developing a systemic reaction with subsequent stings. And the lower end of the range is for the people who has milder reactions. The higher, the 75%, this is for the patients who have more severe reactions that are more at risk of developing a systemic reaction. And we can see here, even asymptomatic patients can have, this is called sensitization, so that means that they have IgE for, I don't know, hymenoptera or fire ant. They have asymptomatic sensitization, and the risk of developing a severe reaction is low, is 5 to 50%. The patients who have large local reactions and cutaneous systemic reactions, they are pretty much similar to the patients who have an asymptomatic sensitization. Few years ago, the patients who had cutaneous systemic reactions, we were also considering these patients for venom immunotherapy, but now after more studies regarding systemic reactions, we know that they have similar risk or slightly higher than large local reactions. And so in general, you want to send patients within these two categories because we can evaluate them and we can decide if the patient needs to have a skin testing in order to start a venom immunotherapy. And what we do, so the most important tool that we have if the patient had a severe systemic reaction is the clinical history, is the primary evidence. We will ask about the nature, the timing of the stings in the past, and even the location of the nest can be helpful to know what was the insect that caused the reaction. The time course of the reaction will let us know if this was a toxic reaction or IgE-mediated reaction, a delayed reaction, okay? And what were the symptoms and the treatments that the patient received. It's also important to know the number of stings and the location in the body. And what we do with the patient, so we do allergy testing, and we do it on like several concentrations. We start with the more dilute, initially as a prick test, and then we start increase the, we start also very dilute for the intradermal testing, and we start increasing concentrations until we reach certain amount that we know is not gonna cause irritation on the skin. We have a viable standardized venom extracts from the hymenoptera family, from the hymenoptera order, and these include all the species that we talk about: the honeybee, the yellow jacket, yellow hornet, the white-faced hornet, and the wasp. And we have also a viable mixed Vespid extracts, so that means these three insects. And this is mainly for treatment. We use it sometimes for treatment. The companies, they extract the venom from the insects, basically. For fire ant, there is a viable whole body extract. It's not the venom by itself. It's more the whole body of the fire ant. And so sometimes we have patients who have a convincing history, but they have a negative skin testing, and we need to repeat the testing, the skin testing, or also do in vitro test. And in vitro test means venom-specific IgE, and these are done on patients who that they cannot have skin testing for any reason, or patients who have a negative venom skin testing. And these don't correlate well with the skin testing. Our first step is to do skin testing. There is other test. I just wanted to mention the Basophil activation test. And in these tests, basophils from the patient with a suspected hymenoptera allergy are exposed to the hymenoptera venom. And what is measured is the activation of the basophil as an expression of this molecule CD63. This test is mainly done for research, has been done in patients to determine if the venom immunotherapy has been successful. However, there are so much technical challenge, mainly the short half-life of the basophils. Of course, the gold standard will be to have a sting challenge test, but this test is difficult to do. There is risk for serious reactions, and is impractical. The other thing is that honeybee is consistent when they sting, but the best bits, it varies. And when they have done these tests on research, they have noticed that some patients don't react on the second sting, but they will react later on. So if the patient tells you, well, I have history that they have history consistent of a systemic reaction, then they have other sting which cause no reaction. Anyway, we need to evaluate them because they are still at risk of having a severe reaction later on in life. So that risk never disappears, basically. The patient the patients that we are going to consider to give them Venom immunotherapy are the patients who had an anaphylactic reaction from the hymenoptera sting, and the ones who had a positive skin testing or specific IgE in the vitro test. And our goal is to prevent systemic reactions in the future, okay, to decrease mortality and to decrease anxiety, because this may improve their quality of life. Especially if this is important in patients who cannot avoid the stings from the insects because of their jobs. So the Venom immunotherapy is highly, highly effective, and we treat the patients to all the positive results, because the patients can have a specific IgE or a positive skin testing to more than one of the hymenoptera order. The Venom immunotherapy reduced the risk of subsequent systemic reactions to just 5%, compared to 60% of the untreated patients. And the patients who are on Venom immunotherapy that have insect sting, they have a milder reactions. However, Venom immunotherapy can give you systemic reactions in some of the patients, especially on the first weeks of starting the allergy treatment. All patients need also to have education about preventions of the stings. The most effective measures, of course, is avoiding outdoors, but mainly preparing or like grilling, eating outside, flowering plants, especially without any gloves. They need to avoid drinking from straws, cans, or bottles outdoors, because we talk about some of the, especially the yellow jacket, can be on trash cans looking for food. The trash cans should be covered. They need to wash for nest, and they need to avoid barefoot, especially with fire ant. There are other measures that there have not been proved to be as effective as these ones, but in general avoid fragrances or like colored or clothing with flowers. That helps to decrease the incidence of stings. And so as a conclusion, the sting and insect allergy may result in a considerable morbidity and even mortality, and all patients with history of a systemic reaction need to be evaluated in allergy and immunology clinic because they are possible candidates for Venom immunotherapy, which is highly effective. And that's it.
Thank you, Diana. That was a great presentation. So open for questions or comments. So Diana, you may have mentioned this, but when you do the testing for hypersensitivity, if you've been bitten by a certain hymenoptera, do you tend to develop cross-reacting hypersensitivity to the other? So how common would it be that you would be then hypersensitive to multiple types and?
Yeah. So first of all, most of the patients, they don't know what was the insect. Even if they say it was a wasp, we need to test for all of them. So if it was a flying insect, we do a skin testing for honeybee, for the 3 Vespids, and for wasp. And there is cross-reactivity in between them, especially the Vespids, because when they are from the same family, they are gonna have a higher cross-reactivity. And this cross-reactivity is mainly on skin testing or when we measure a specific IgE on the blood. However, because we are detecting antibodies, we need to treat to all the positive tests that we have. But yeah, so Vespids are the ones that cross-react the most, so yellow jacket, yellow hornet, and white-faced hornet. Wasp cross-react a little bit with the Vespids, and honeybee doesn't have too much reactivity with the rest. Mm-hmm.
So is it because there's a particular protein that's in the
so
venom
they,
that sort of cross-reacts?
Mm-hmm, yeah, so they share some proteins and antigens that if you produce an antibody against a certain antigen, is gonna be also in the venom from the other family, like the same members of the family.
Do you prefer the EpiPen or the acute, and is there cost issues with that as far as prescribing it?
Yeah, so the most important issue is the insurance coverage. We have some insurance that approve the AviQ, but for the most part, we have, since we see mainly Medicaid, Medicare, they usually cover the generic epinephrine auto-injector. Mm-hmm.
Okay, other questions, comments? Dr. Muhammad?
Well, I commend you for this wonderful presentation. Very, very good. Particularly emphasize the point of the stinger stays in the skin, particularly by the honeybee, because we tend, if there's something itching in the skin, we automatically go and rub it, and rubbing will be worse. So we're squeezing more the venom further. You showed the picture how to flip it out without squeezing in this. We also emphasize that 5 to 10% of patients have anaphylaxis from the first sting. This means they have been stung before and they did not care about it. It was very small, very mild, and passed. This forgotten, simple sting sensitized the patient. The patient did not remember anymore. Do you think some of the patients who die in the street and they wrote as heart attack can have anaphylaxis to the insects?
Yeah, I mean, it's possible. There are patients who have been even admitted for other reasons, and we have seen that in some of the case reports that they have very severe reactions that nobody knew what was going on, and they are admitted for the reason because they don't, if they are not able to tell, or if the local reaction is really mild, they may not know what happened, and definitely they can die after insect sting before going to the hospital.
And some doctors who did the autopsy on them, they took blood and they found their taste level was high in some of these patients. So definitely died from an acute reaction, probably the insect. For how long do the allergy shots for these are given?
So for these patients, even for life can be considered, but at least 5 years they need to be given on Venom immunotherapy. But every case should be evaluated individually because the patients may benefit of immunotherapy for their entire life.
Can 3 years be enough?
It can, but it's better 5. Yeah, it's better 5 years.
Some patients, after 3 years, they can be right, particularly the reaction. And them was not very severe systemic, and during the immunotherapy went smooth. There were no reactions in the mountain. Can these shots be given at home?
No. No, because every time that we give a shot, there is the risk of a severe reaction. So it needs to be given in the clinic, and the patient needs to be watched for at least 30 minutes after the shot. I mean, it depends on the schedule that we use, how long the patient needs to stay in the clinic.
Very good. Is there any more questions?